Welcome to Pulse Pressors, where critical care gets crystal clear. Phenylephrine is a pure alpha-1 agonist with no beta activity. Its ICU use has declined as evidence favoring norepinephrine accumulated. It occupies a narrow clinical niche. Phenylephrine acts directly on alpha-1 receptors. Metabolism is primarily hepatic conjugation, sulfation, and glucuronidation, plus MAO breakdown. Importantly, phenylephrine does not rely on COMT for degradation, unlike endogenous catecholamines such as norepinephrine and epinephrine. This non-COMT pathway allows phenylephrine to be used in patients on MAO inhibitors, though dose modification is critical. It produces no active metabolites, giving it a predictable, titratable profile. Pure vasoconstriction increases SVR without affecting heart rate or contractility directly. Increased afterload triggers baroreceptor-mediated reflex, bradycardia, often reducing cardiac output despite rising blood pressure. Indications are limited. Hypotension with preserved cardiac output, especially when tachycardia must be avoided. Common in anesthesia for procedural hypotension, but rarely sustained in the ICU. Phenylephrine raises MAP without increasing heart rate, or while decreasing it. Useful in atrial fibrillation with RVR, SVT, or when beta stimulation is undesirable. Its non-COMT metabolism allows use with MAO inhibitors when necessary, with appropriate dose adjustments. Infusions range 0.5 to 3 micrograms per kilogram per minute. While generally given as a continuous infusion, a rapid 50 to 200 micrograms IV bolus is occasionally used in the ICU to temporarily stabilize severe acute hypotension, such as during intubation or when MAP drops below 40 millimeters of mercury. While waiting for a continuous infusion of a first-line agent like norepinephrine to take effect, high doses cause severe vasoconstriction and tissue ischemia. Phenylephrine increases afterload without compensatory inotropy. Reflex bradycardia further lowers cardiac output. Tissue perfusion may worsen despite elevated MAP. Reflex bradycardia is nearly universal. Cardiac output typically falls. Peripheral ischemia occurs with moderate to high doses. Septic shock studies show increased mortality versus norepinephrine. MAP rises via pure vasoconstriction, but cardiac output falls due to increased afterload and bradycardia. Stroke volume is unchanged or reduced, poorly suited for ICU shock states. Norepinephrine combines alpha and beta activity, vasoconstriction plus inotropy, maintaining or improving cardiac output while raising BP. Phenylephrine raises blood pressure at the expense of cardiac output. Mortality data favor norepinephrine in septic shock. Phenylephrine is inferior to norepinephrine in sepsis, offers no benefit over vasopressin, and is outperformed by ephedrine in obstetric hypotension. Its only role is refractory tachycardia requiring MAP support. Not recommended first-line in septic shock. Raises SVR and MAP, but worsens microcirculatory flow. Higher mortality in trials. Reserved for intolerable tachycardia when norepinephrine or vasopressin cannot be used. Reflex bradycardia may reduce oxygen consumption, but phenylephrine doesn't improve ventilator synchrony. It worsens RV afterload, making it dangerous in RV failure or severe ARDS. Pure afterload increase is problematic on mechanical circulatory support. No inotropic support. Worsens LV distension on VA ECMO and increases RV afterload on VV ECMO. Norepinephrine or epinephrine are superior. Phenylephrine fell out of favor due to clear evidence. Septic shock trials showed worse outcomes versus norepinephrine. Reflex bradycardia and reduced CO work against tissue perfusion goals. Modern ICU practice prioritizes perfusion, not just MAP. Role limited to brief procedural hypotension or rare tachyarrhythmias with hypotension. Expect bradycardia. Watch for falling cardiac output. Track lactate and perfusion markers. MAP may rise while perfusion worsens. Assess peripheral perfusion modeling, cool extremities, delayed capillary refill signal, excessive vasoconstriction. This is Pulse Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.